This is the second of 4 webinars in our safety series. I'm Dale Singer, RPA's Executive Director, and I will be serving as your moderator this afternoon. Your lines are currently on mute. Should you want to ask a question or make a comment, please click Raise Your Hand and your line will be unmuted during the discussion. You may also type into the chat box at any time. We ask that you please keep your line muted if you are not speaking, and do not place your phone on hold so that we don't hear music and get disturbed by the external noise. Today's webinar is being recorded. I would now like to introduce Renee Garrick. Dr. Garrick is a former member of the RPA Board of Directors and currently serves as chair of RPA's Quality, Safety, and Accountability Committee. She is also a professor of clinical medicine, vice dean, and section chief of the renal division for Westchester Medical Center, New York Medical College. As executive medical director for Westchester Medical Center, she oversees quality, safety, and regulatory initiatives and has extensive experience with quality initiatives as they relate to patients with kidney disease. Dr. Garrick will kick off today's program.
Thanks, Dale. It's my pleasure to welcome everybody. I think that everyone on this call today knows that we've pulled together this stakeholder group to look at areas in safety that we might use our collective activities and leverage those activities to improve safety in the dialysis facilities around the country. Last week, Alan Kleiger and Tammy Keir led us in the conversation about the culture of safety in dialysis units, and today's webinar is going to focus on one of the main safety issues that has been identified across dialysis facilities across the nation, and that's medication reconciliation. And if we can have the next slide. We're being joined today by Dr. Manley. Harold Manley is a pharmacist and the Director of Medication Management at Pharmacovigilance Program, and he has over 20 years of experience in various settings, including community and institutional pharmacy, academia, private and government health plans, administration, and disease management. He also has huge expertise specifically in the dialysis population and has individual unit management experience and corporate management experience in operations, planning, strategy, and information technology. So we're really very happy to have him with us. So welcome, Harold. And today what our plan is that we're going to go through a talk that's aimed at exploring, as we'll see on the next slide, some of the challenges. Amy, if we can have the next slide. Some of the challenges around medication safety. And we thought we'd begin by starting at the very top and learning from our patients and learning from what our patients and our staff have told us about what they experienced in our units. In 2007, the RPA did a survey, and the patients said to us, you know, we take a lot of medications, 6 to 10 different meds a day, and we only sometimes discuss those meds with our doctors. And they explained to us that on some occasions they were discharged in what they thought was a new medication. The patient took it, and it turned out it was a different name for something that I was already taking. My pressure got so low, I had to go back in. When the ESRD Forum did their Transition to Care survey in 2014, 61% of the patients said they were felt unsafe during hospital admission time, and 47% of patients said they felt unsafe at hospital discharges. A lot of that concern was around medication management. Patients explained to us that discharge from the hospital was hard for them. They gave me lots of information all at once. I didn't really understand it, and I just wanted to go home. And the staff have similarly called out medication reconciliation as an area of great risk. The ANA Culture of Safety survey taught us that 12% of respondents said that medication errors occurred weekly at 6% and monthly at 6%. And 30% of the respondents said they had a problem exchanging information with pharmacies. On the RPA survey in 2007, 23% of the respondents estimated that over the prior 3 months, medication errors had sometimes occurred. So we all agree that this is an area of great risk, and the next slide brings us to what we want to focus on today. So we want to focus on what the available data are around medication reconciliation and medication management. We want to spend some time talking about how medication management is currently approached in our facility, what resources, training, and systems are employed, are they actually effective, and do we audit their effectiveness? We want to share best practices that are available, and then spend some time looking at specific realistic steps that can be taken to improve medication management within our facilities. So in the next slide, we see that just like Einstein taught us when his first manuscript of his secret to amazing problem solving, the first key is to first define the problem. So medication-related problems have been defined as undesirable patient events that are involved or suspected to involve drug therapy. And they include that big catch. They include all the adverse events, all the overuse, all the underuse, all the incorrect use of medications that could go on within our dialysis facilities. And Dr. Manley is going to take the next slide and walk us through some of the data around how we can try to prevent these medication-related problems. So Harold, welcome. I think Harold should have his mic on. Amy?
Hello? Hello,
there you go. Okay.
There we go. Excellent.
So there's Harold. Okay.
All right. So I apologize. For
That's
some
okay.
reason I was on mute. So yeah, thank you for the introduction, Renee, and for the audience. So Renee and I will be going back and forth. It's like a tag team presentation, and hopefully you enjoy this type of format. So as Renee mentioned, that we defined the problem, medication-related problems, a whole host of different reasons why they can occur in dialysis patients or any of our patients actually. So how are we going to address these issues called medication-related problems? And we're all scientists. We think in formulas. So I think the formula for success would be to break it apart for medication management, and it constitutes two parts: med reconciliation and med review equals med management. Specifically on each issue, when I think about med reconciliation, it's maintaining a medication list. Sounds easier than what it really is to actually maintain this medication list, but we realize that it is a process where we have to verify all the medications, name, dose, formulation, etc. And it has to be performed at regular intervals, and at minimum at every care transition, because there's a lot of change at that point in time. And thinking about the medication reconciliation process, again, simply maintaining this list, and I use the word simply in jest, but this list is preparatory to the review process. It really takes a clinician to evaluate this medication list that is placed in front of them. And when they evaluate it, as you can appreciate, there they are looking for the various medication-related problems. Be it, are the meds safe and efficacious? Are they, on the right dose? Are they on meds that they no longer need, or do they need meds that for that indication that's not being treated? So it's this combination of two separate and distinct processes, one for med reconciliation and one for medication review. Those two separate processes equals medication management, and that ultimately requires a lot of training and knowledge. So I think this is a good time to go to the next slide, but also ask the first poll question to the group. So the format here is that you should be able to respond by clicking on the various boxes here. And then once the responses come back, we'll discuss them briefly. So at your respective institutions, who is it that performs med reconciliation for your patients? So if you could respond, that would be great. So it looks like 50% of the respondents say the dialysis nurses perform it. Good amount of mid-level providers. That's great. And physicians conduct it about 20% of the time. Perfect. All right. So you can go to the next question, if we could. So during this process of med reconciliation by nurses, physicians, mid-level providers, do you feel that you have a reliable, structured process in your facility? 80% of you say no, which is really interesting. It's probably consistent with what you'll probably see later. And 10% say you have a really structured program, and 10 not sure. Thank you. So thank you to the audience for replying to these poll questions. And I'll turn it back to Renee.
Okay, well, that was very telling and probably explains why we have these kind of events. So we thought that, like lots of safety conversations are good to start with a story because they tend to be very effective ways of communicating. So Harold and I picked out a story that could have gone on in any dialysis unit, happened to go on in the dialysis unit that I know well. This is a 22-year-old woman who had severe hyperparathyroidism and hungry bones with a high alk phos and underwent a parathyroidectomy. And med reconciliation and discharge meds were actually discussed in detail with the patient and the hospital by a nephrologist, and a copy of that list was sent to the hemodialysis facility. That was on a Thursday, and the patient was discharged on a Friday morning by a different hospitalist. Medications ordered in the dialysis facility reflected the plan of the nephrologist and included daily calcitriol and 6 grams a day of elemental calcium. The next week, the patient was readmitted with a calcium of 6.1. We can see on the next slide that we reviewed that event and we discovered a lot of issues. The first was that the discharge electronic script from the hospitalist was actually for liquid calcitriol, and it was e-prescribed and dispensed as 1 microgram per ml. That was the dose on the bottle. And the e-script told the patient to take 3.5 mics a day rather than in mils per day, and the patient, having no idea what that meant, took a dropper full. The calcium was ordered as calcium carbonate, 1,250 milligram tabs, 500 milligrams calcium per tab, take 8 grams a day. The patient interpreted that as taking 8 tablets a day, and remarkably, the script was only for 14 tablets. And the discharge medication list from the hospital included Sensipar, which the patient had been taking pre-op, and she thought it was fine to continue on it. On the next slide, we'll go through what the root cause showed us, and the root cause was done by the nephrologist, the primary hospitalist, and the dialysis staff. And it discovered that the discharging physician actually didn't notice or understand the issue of selecting liquid calcitriol. They didn't notice that the order was in micrograms per mil rather than just in the final dose to the patient, and that resulted in confusion for the patient. The prescriber didn't understand the plans for elemental calcium. This was the second hospitalist who hadn't reviewed things with the first hospitalist or with a nephrologist, and they only gave the patient a couple of pills to tide them over until the dialysis staff could figure it out. They continued Sensipar, believing that since the patient was taking it at the time of admission, it must still be needed. The discharging RN at the hospital said that she read aloud the e-prescribing form to the patient. The dialysis staff didn't realize there were 2 different medication discharge forms, and they only reviewed the names of the medication with the patient on Friday, and they used the list that the nephrologist gave them, and her nephrologist didn't see her at the time of her discharge in the dialysis facility because the nephrologist typically rounds on Wednesdays. So if we look at the anatomy of this event on the next slide, it's easy to see that, like a lot of root causes, it was a failure to communicate. And we often refer to that as the Swiss cheese effect. And so the big drivers of risk aren't that surprising. It's complicated medications with lots of changes, with very fragmented care, with lots of providers, with inadequate education of patient and staff. Medication management occurred at discharge, so it was likely pretty rushed when the patient was trying to go home, her ride was coming, and the follow-up was not adequate. And on the dialysis side, we have the holes lining up now because there was a communication breakdown between the facility and the unit. There was a poor handoff between the 2 hospitalists, the guy who the nephrologist talked to and the person who actually did the discharge. Then there was certainly a poor handoff between the hospital and the dialysis facility. There was a knowledge deficit that led to a failure to recognize and therefore be able to mitigate risk. and there was clearly a lack of hardwired safety tools, and as a result of all this, the medication discrepancies were able to reach the patient. So we can see on the next slide that these kinds of risks are ever present, and we have a little poll question to ask whether or not, as a group, do we communicate our medications effectively across the continuum. So let's see how we do with this. I don't know, Amy, can you advance it? There you go. So 67% say they do it with, I have a big echo now, with every stay. 11% say they gave it to every engaged providers. 11% only do it on request, and a little less than half say we don't have any special process in place, which is probably why, as we're going to see on the slides going forward, we have a lot of disconnected care. So if we can have the next slide. One more, I think. One more forward.
One moment, we're having a little technical difficulty.
Okay, that's okay. So the next slide we're going to talk about, Harold's going to give us some analysis here of some of the challenges that one back aim, that, there we go, that are faced with. So you see some of the challenges, and Harold's going to walk us through some of the issues surrounding medication safety and some of the remarkable data that we've learned. Harold?
Thank you. So yes, medication-related problems. We can all really appreciate that they frequently occur. We can think that they're associated with hospitalizations. You know, they are found on admission and on discharge. We've talked about effective communication, and what we haven't brought up just yet is improper record keeping. But the purpose of this slide is to, excuse me, give you some numbers on how many patients are affected by these types of issues if you were to do a literature evaluation on, medication-related problems in end-stage renal disease patients. So highly prevalent issues, a whole host of issues in our patient population. So what are the drivers of change? Well, clearly, patient safety is a priority in every organization. At previous slides said that medication-related problems, MRPs, are frequently occurring, and there's review articles on there on that issue in and of itself, and we'll put up at the very end of the session. I guess that article, will share it with you. Medication management is a safety initiative, be it from AHRQ, the Joint Commission, CMS. Many organizations recognize this. And if you think about the value-based care models, the new care models that are coming out, readmission is an initiative for it, and thinking how medications can impact the index case for hospitalization as well as readmission. So med safety is a high priority. There's some literature out there that if you provide medication management services to your patients, it's estimated that in the dialysis population, for every $1 invested, the healthcare system saves $4. And if you look at the regulatory bodies, if we're a Part D plan, CMS says under the Medicare Modernization Act of 2003 that all health plans, Part D plans, have to have a medication therapy management, a drug safety program for all enrollees. And then thinking about the patients that we serve in the dialysis units, 80% plus of them may be part of or using a Part D plan, and therefore are impacted by some sort of medication therapy management program. And as dialysis providers, under conditions for coverage, there's even a V tag on immunization and medication history, BTAG 506. And if you actually were to read it, it's really interesting from my perspective that a medication history should include a review of all the patient allergies, but it's all the medications, not just those that we prescribe or that are, that other prescribers write for our patients, but it includes over-the-counters, supplements, and that all this information needs to be put into our records and an assessment of all those medications, the prescribed, over-the-counters, vitamins, herbal products, the nutraceuticals, whatever that they're taking, is being reviewed for possible adverse effects and interactions and continued need. So under conditions for coverage, we're supposed to look at the entire list. So yes, next slide, please. So the process of medication reconciliation is, if you look at the Institutes of Healthcare Improvement definition, it is the process of identifying the most accurate list of all the meds that the patient is taking and using this list to provide correct medications for patients anywhere within the healthcare system. So, it sounds simple, right? So you ask, well, maybe it would be great to have like a brown bag day. You have the patient bring in all their medications and put it in a brown bag. So if you go to the next slide. I don't think some patients have brown bags big enough because we asked a patient to do this, and that brown bag turned into their rollerboard suitcase. They just needed something that's just physically big enough to hold all the medications that they had at their disposal. And when this patient brought in this suitcase full of medication, it literally took about 2 hours just to sort it out and really figure out what the patient should and should not be on. So next slide. So brown bags turn into suitcases, and we think, well, medication management must be easy, right? And well, the short answer is no, because we all recognize that the average dialysis patients, take 11 to 12 meds, multiple doses of pills per day. These regimens are very complex. They have multiple prescribers, 3 to 4, sometimes more. The communication chain at best is fragmented, but most often it is unlinked between these various providers. So because it's fragmented, unlinked, different individuals doing it, the med reconciliation process is, like I said, done in varying and disconnected sites. So there is that hope that the electronic health record would be, would solve it all, and everything's going to be connected and everybody knows what's going on in the patient. But we realize that it has not been the panacea for our patients. And based upon the RPA survey, only 10% of the respondents say the electronic health record systems are linked. And even if you have these electronic health systems, record systems, these systems allow for workarounds so that there appears to be a stream of inaccurate and incomplete data, and that the oversight mechanisms for MedRec are well intended. However, they're not completely able to catch and resolve all the various issues in our patients. So if we go to the next slide, and another poll question. Again, thank you for responding to these poll questions. But for this one, how often does your facility mandate that med review occur in your patients? If we could move forward, that'd be great. At every transition, that's awesome. 63% of respondents. And at every care plan meeting, that's great, 25% of respondents. So next slide. I had mentioned that Medicare, under the Part D plans, they have a medication therapy management program, MTM. So that's the Part D plan version of the medication review. Those regulations state that a patient, at least annually, has to have a comprehensive medication review if they meet their MTM criteria. And when I think about how does that apply for our dialysis population, it'd be great to have it coordinated with the annual care plan. During that process, it's a person-to-person interaction process, so video, telephone, face-to-face conference with the patient, where you're looking at all the health goals, all the medications, all the problems. You're discussing, you're having a earnest conversation with the patient, and looking for many cost-saving alternatives, making the regimen simpler, trying to assess compliance, and at the end making recommendations based upon this conversation. So that has to occur at least annually. And then CMS requires MTM programs to have targeted medication reviews quarterly, at least quarterly. These types of reviews could be a follow-up from the comprehensive medication review, or they could be just something that's scheduled for that given quarter, or they could occur after a special event or a sentinel event like hospitalization, a fall, or they could occur upon referral. But they need to occur at least quarterly. Next slide, please. So when conducting, I guess, a medication management program for your patients, it's three things that we need to think about, the barriers for this program. Sometimes the information is hard to gather. Patients may not necessarily understand the conversation that you're about to have with them. They have different literacy around it. They may not recognize that the things that they take over the counter, or the vitamins and nutraceuticals, they may not consider those medications, so we need to have probing questions for them. We've already mentioned that there's multiple prescribers. The electronic health records aren't linked, with disparate med-rec processes occurring in different locations, which makes it hard to coordinate this information. And there may be a perceived barrier to HIPAA, by HIPAA. To do this process, it takes a lot of time to do it accurately and completely. And unfortunately, med reconciliation oftentimes plays second fiddle or is on the back burner to the other competing tasks that occur and in the dialysis clinic. Like, for example, we need to make sure we have a safe dialysis session for our patients. So performing med reconciliation and med review, takes is on the second burner compared to that sometimes. And I already mentioned it takes time. So even if we had all the time in the world to perform this for our patients, we need to make sure that our staff are educated and trained and held accountable, and there's clear accountability across the spectrum on who is going to do, when it's going to occur as it relates to med reconciliation and med review. So the next slide, please. So there's a good paper by Gleason talking about the MATCH program, and he puts out there a laudable aspiration about the medication list, as being the one source of truth. The medication ideally should be shared and utilized by all. It should be centrally located, and it's easily visible and attainable, and really serving as a reference point for many clinical decisions. And then ultimately stored and retrieved upon need, and can be reviewed and modified as needed. And each discipline should be empowered to update it and held accountable for updating it and communicating effectively. So a couple more poll questions. So does your facility teach how to obtain the best medication history? %, say no. And the next question is, when a medication review or med reconciliation occurs, are you have an audit process to make sure that it is complete? Is it part of QAPI? And I can anticipate what this is going to say too. 80% say no. All right. Perfect. So I guess now back to you, Renee.
So thanks, Harold. So one of the things that when we thought about these safety conversations was we wanted to try to think about whether or not there are things we could do to improve care and leverage all the activity that all the various stakeholder groups are doing in the world of dialysis. And the clear value proposition is we want to try to do things that can improve care, reduce expense, and fulfill the triple aim. It seems to us that MedRec is obviously a pretty key area of safety within our units. And so thinking about a process improvement approach, we think that the things we'd have to think about are ways to build an interdisciplinary team, which would need management support. There has to be buy-in. We think it should be started with a typical PI process of looking at a flow chart for the current medication reconciliation and med management processes within each of our units. Then we look at a work plan for how to structure it, how to embed it in the workflow so that the nurses and the staff can actually do it in a reliable way. Staff have to be educated, and the unit will have to make that available. And then we'll have to choose some outcomes that need to be measured and then audit those outcomes. And we can look at the next slide, kind of look at a graphic approach to this. So everyone needs to know their role and needs to understand exactly what they're supposed to do, because if it's everyone's job, it's no one's job. And one of the things we've all learned as trying to move forward PI projects is that it has to be clear what we're aiming for. So if we can look at the next slide, this is a typical medication reconciliation process. And you can see that this takes a lot of training. Just telling a nurse or a doctor, go do MedRec, is nonsense, because you have to understand what it is you're trying to look for, what data you need to ferret out. And on the next slide, we can see that that process involves lots of brain power. So to take a so-called best medication history, you need to be able to understand that you need more than one source of information. So you have to have interviews with the patient, the family, other caregivers. It's not just enough to look inside that suitcase and identify the bottles. You have to look what's inside the bottles, because if you're like my husband, you mingle all your drugs together in one bottle for ease of carrying, so the label actually has no meaning on his drugs. You have to look at the pharmacy and look at all the meds from all the providers, and all that has to be put into the medication reconciliation process. And on the next slide, you can see that in order to do that, there have been lots of groups that have tried to give us guidance. So ARC has medication toolkits, which we can all use. The MATCH program that we just showed you some data from has videos and other toolkits that can teach us how to do a best medication history, and those videos are available online. The Marquee gives a guidebook for medication rec improvement processes, and so does the ESRD form and the networks and the 5 Diamond program. And you can see on the next slide that the Marquee group has put together a really nice trifold that you can put in your pocket, put up in the unit, that tells you the steps for MedRec, tells you how to go about developing probing questions, and then how to make a nice medication reconciliation format. This is readily available, and these are tools that we think could be implemented in our units. And on the next slide, you can see that the data are very clear. MedRec is not something that we can just take lightly. It takes skilled pharmacists who know exactly what to look for and understand their meds, 20 minutes per patient to do adequate MedRec. And I would challenge everybody on this call to think about whether we give that kind of time in our dialysis units per patient for medication reconciliation, which we all just agreed should be done at every transition. And I'd ask, are we really doing that and doing it effectively? So in the next slide, you can see that a couple of years ago, just this summer, the CMS put data out to show just how potent MedRec is. And this is from patients with chronic conditions. And on average, this is people with kidney disease and other chronic conditions. There are 13 different doctors engaged in their care. This is from the CMS administrative database. They fill, on average, 50 different drugs a year, not just all losartan, but 50 different types of drugs. They account for 76% of all admissions, that is medication. And these patients with chronic disease are 100 times more likely to have a preventable readmission. This study, which was published in this summer in May in the Journal of American Pharmacological Association, demonstrated that pharmacist-directed medication management within 1 week of discharge reduced readmissions from 20% to about 7%. And on the next slide, you can see that this is very similar to what the ASN work group discovered in 2013 when they put together that perfect medication reconciliation process. And they said the same thing, that if we really want to do MedRec, everybody has a role, and you can see on the outer circle, and the pharmacist may be a pivotal person in that role to try to tie together this. And with the next part of the talk, we're going to talk about work that Harold's done to implement what the ASN's work group and advisory group put together on how to do a best medication management process within dialysis. So Harold?
So I'm not saying this is the best practice. I'm just saying this is a practice. This is what we've been trying to implement in our dialysis clinics, especially where we're going to have our ESCOs. And we call it the REACH MTM program. Everything in this world is an acronym. So REACH is Real Engagement Achieving Complete Health, and MTM is Medication Therapy Management. So the next few slides, I really want to just paint a picture of what our process is, and whatever any organization, any listener on the phone can take away pieces of it, by all means, please do, because ultimately the aim is to improve medication safety in our patients. So like any medication therapy management process, it is a process where you have to do some sort of assessment, create a care plan around it, and then do a subsequent evaluation of what you identified earlier and had the care plan around, and then repeat this at regular intervals. So ultimately, programmatically, that's how we operate. We have, on the next slide, two central themes, two central messages, one for the clinicians, one for the patients. I work with a bunch of nephrologists. They love to see the acronym SCR. They think serum creatinine, so how can I use it so that nephrologists can, one, remember it, and then two, do something about it. So I said, well, there are medications, serum creatinine, or medication SCR. Meds have to be safe, they have to have a continued need, and they have to be reconciled. So using that acronym, was able to work with clinicians and help them, have the right frame of mind, at least from my perspective. And from the patient side, even for our CKD patients or any patient population, the message I want them to have is, before you take any medication, think how it will impact your kidney function, and then realize that your kidney function will impact what medications you can take, should avoid, the dosing issues around it. So the medications and kidneys are intimately related and have an interplay between the two. So graphical, easy message for the patients, and they get it. So next slide. We go through this process of an assessment, care planning, evaluation, and we create a variety of documents. We have documents for patients and providers that we call it the medication action plan, tailored to each individually, using the appropriate language for patients for the medication action plan. So it's a personalized health outcomes tool that makes recommendations and monitoring that they can do themselves or bring to their provider and raise these issues up. We have a similar medication action plan written for the clinician, the provider, with specific recommendations around specific issues for their assessment. And I will show what our document looks like momentarily. After every encounter, we'd like to give the patient a medication list so they know what the reconciliation, at least the list looks like at that point in time, and they can share it. And we can provide provider summary reports of the entire interaction that we had with the patient. So the next slide. So I mentioned the medication action plan. It has 5 sections. The top section is, what are the names and allergies the patient has, what is the average drug reaction. The next section is, okay, here's the issue that we identified in the patient. For example, this is a peripheral neuropathy, a patient that has on Sensipar. We gave some information that of the other meds that the patient's on. Here's the risk of paresthesias. Maybe the paresthesias, this new onset paresthesias, is associated with the new onset of this Sensipar starting. So there's the recommendation of note. you'll see where it says accept, reject, noted, or refer to other provider. So here's the opportunity for the nephrologist to say, okay, I agree with the recommendation, I don't agree with the recommendation. All right, well, thank you for this piece of information, that's noted. And I'll just tuck it away and use it again later on. So it's not an issue in this patient at this point in time. Or it may be an issue that we're bringing to the nephrologist's attention that they weren't the prescriber of it, but they need to be made aware of it. And they'll say, okay, refer this issue to that other provider. All right, so we put these recommendations in context to the medication list. You know, it's nice to have a recommendation and be able to say, okay, how will this impact the other medications that the patient's on? So that's 3 of the 5 parts. And then the next slide, the other 2 of the 5 parts is, you know, the continuation of the med list. But on the bottom, it is a signature line for the physician to say, okay, you know, do whatever was happened north in the document where, you know, accept, reject, given recommendations. And there's also an evaluation comment, just any more information that the pharmacist wants to provide is provided here as well. So that's our process. So over the past 2.5 years, honing this process, we were able to deliver it to about 1,400 patients. Our mean age is 62 years of age, you know, roughly 50–60% male. And we've conducted, you know, over nearly 3,100 medication reviews and identified on the very bottom of the slide over nearly 7,500 issues, and we put those in front of the nephrologist for his or her consideration. So next slide. The types of issues that we've identified, you know, range the spectrum of different types of medication-related problems. They could be adverse drug reactions, a compliance issue, dosing issues, either the meds too high or too low. Maybe the patient would benefit from a different medication. So you can see the individual type of medication-related problem identified, the number and the frequency of those issues identified here. Next slide. We've repeated this process in patients over time. The very first time that you have this process in a patient, formalized process, we identified, you know, 2.8 problems per patient. But over time, roughly every quarter this would occur, the number of medication-related problems identified decrease over time because you're addressing things previously. So we can show that we're having this type of impact on our population. Next slide. So this is the mean averages, the means for the patients. But if you look at another way it represents this data is the blue line these are the percentage of patients who have no issues identified on when they do a medication review. You know, the very first time you review a med list, 10% of the patients would not have any issues. So that means 90% of the patients do have some issues. And with subsequent reviews, that ranges around 20% of the time. So 1 out of 5 patients have no issues, or 4 out of 5 patients have at least some issues. And the other color lines represent roughly how many issues do you expect to find in a patient population, depending on if it's your first or your 5th or your 6th visit. So you would anticipate that the number of problems identified, having 1 or 2 problems would increase because that's roughly what you would find. But the number of patients who have like 3 or 4 or 4 or 5 problems decreases over time because you're addressing those issues. Next slide. The reason why we've created a program like this is because of published data that shows if you provide these types of services to dialysis patients in this small pilot study at least, where they are randomized to receiving med management or standard of care, that patients who received med management had fewer medications, and that held consistent over time. Next slide. And importantly, these patients had fewer hospitalizations compared to standard of care, and if they were hospitalized, they had shorter lengths of stay compared to standard of care. So I'm not really too hung up on the actual numbers per se, but the direction of the data illustrates that there may be something here. So this was based on 75 patients in each arm, standard of care or receiving med management. But if we looked at our data in the next slide, it is consistent with what was previously published, that when we do a MTM review post-hospital, that since January of this year to August 31st of this year, using a collaborative process with nursing, pharmacy, and medicine, we would reconcile and review and make recommendations, and this process resulted in fewer readmissions in our patient population. We excluded, nursing home patients in this analysis, but nonetheless, it was very interesting to see that our readmission rate was around 15% when we had this structured process in this population, and that's impactful. Not only does it not only reduce the readmissions in our population, but you can put a financial value associated with that. And for ease of math, if we assume $10,000 per admission, we would expect 134 readmissions in these 294 patients over this period of time. We experienced 65, so we avoided 69 readmissions to the tune of around $700,000. So I think it was interesting, still preliminary data, but it's all pointing in the right direction. So we're continuing to evaluate our program. All right, so the next slide. So I guess this is the end of the presentation, and the obligatory, questions slide comes up. But in the spirit of, turning the tables on the audience, I thought we would pose some questions for you to consider, and we would love to have a conversation about this. So for your organizations, do you feel that med management should be a high priority for your organization? Think about your programs, and are there standard processes for med rec and med review, and standard processes for educating and accountability in your organizations? For those organizations who have, this process in place, do you feel you communicate it effectively? And are you sharing it inside your organization and outside your organization? And then, we're all leaders, but do you think your frontline staff would agree with your answers that you, to these questions and that what you posted earlier?
So we have unmuted the people who've used their PIN to enter into the call, and you can hit the raise your hand button if you'd like to contribute to the conversation, or you can certainly type a question into the question box or the chat box.
Well, maybe can I get started? This is Alan. I'm one of the panelists, so I can't raise my hand, so I'll raise my voice instead. So the program REACH looks really wonderful, and the preliminary data looks very exciting to me. I guess my question is this: we don't have an army of pharmacists or pharmacy technicians to do the kind of med rec that you're recommending, and while I'm sure physicians, PAs, nurses can do it, the detail involved and the attention to it is a little bit staggering to me. How many pharmacists or pharmacy technicians per patient are necessary to do this, and how have you financed it?
Okay, thanks. I just unmuted myself to make sure there was no echo. So we roughly have a pharmacist for every, say, 500 patients, 600 patients. So we're going to have our 3 ESCOs, and each ESCO, ESRD Seamless Care Organization, is going to have a pharmacist assigned to it. We are centrally located. We're using informatics and video conferencing and technology to connect with patients. Our software is interfaced with the electronic health record. As you may appreciate, the ESCOs will be getting claims data, medical and pharmacy claims data. So we're going to be using those interface. And I'm bringing all this up so it increases scale and efficiencies in the program, because you're right, not everybody has the luck or the resources to have, a number of pharmacists. So we have one for every 500-600 patients for our ESCOs.
We've unmuted Cynthia Christensen.
Yeah, hi, this is Cindy Christensen. I had the same concern that Alan has, that is just not having the availability of pharmacists. And I know that even when patients go to the hospital and the pharmacists try to understand medications, they end up spending a huge amount of time even calling pharmacies and calling homes and stuff. One of the things that I found most helpful was getting a home health nurse when there were problems. I know there's certainly data when patients are discharged from skilled nursing facilities that having a home health nurse at the time of discharge decreases the incidence of readmissions. Unfortunately, I think the dialysis units really have to look outside of the dialysis unit to try to make any kind of this.
I agree. So I think how can we either gain more resources so we can hire individuals to do these types of I guess functions and tasks for these patients, or how can we partner with outside entities to to again accomplish this and increase medication safety in our patients. I think it's going to continue to develop, and these services will continue to expand, especially as Medicare looks at continuing to bundle these types of services in our payment systems, or allowing organizations in doing value-based types of care and risk-sharing or cost-sharing initiatives with payers. So I think CMS and various commercial and private payers are looking at the total cost of care, not just the fee-for-service type of care that the dialysis organizations traditionally have used. And a perfect example of that is the ESCOs, the ESRD Seamless Care Organizations, as a means to test this out, and why med management was a requirement. As two or three of the metrics posed relate to med review for the ESCOs. So I think all in all, as healthcare reimbursement changes in the not so distant future, you'll find the resources available to add more internal staff, like pharmacists, technicians, or allows organizations to partner with other organizations because we're paid for outcomes, just services rendered.
So Harold, this is Renee, and I think I'm off mute, but I was thinking, when dialysis facilities first began, social workers and dietitians were part of the original conditions of participation and coverage. And there are VTAGs, obviously, for MedRec and med management, but they're unfunded. They're not supported. And maybe part of the conversation that we should be having is a conversation with CMS about the need for the dialysis communities to understand the importance of medication reconciliation. The data are pretty self-evident. And to really do it right, as Alan said, it's unlikely it's going to be done just by the units themselves, because we don't have all the right pieces of the puzzle and the right information technology to just stand alone. You see how badly, no matter how hard we're trying, and we're all trying really hard, we're not where we want to be. And maybe we should be petitioning CMMI and others to think about different models so that we could do this better and be more linked. That there are cloud-based EMRs now, or cloud-based medication reconciliation management programs that would cut across all the differences in the EMRs and allow us to do MedRec in a central location in the cloud. that maybe we should talk about ways as unifying all of our efforts, that we could talk to CMMI and others about joint activity.
Right. Well, just one practical point, of course, which is, Harold, you make a very nice business case for this, but unfortunately, those thousands of dollars that are saved in preventing admissions and readmissions don't go to dialysis facilities.
Right.
And so you can't expect the dialysis facilities to fund that based on that business case.
Right.
Unless that's why we agreed. So I think this would be we're almost out of time, but maybe Dale and others in the stakeholder group, maybe this is an area that as we continue working through our thinking around safety, that maybe we should put this, in our little box of saying this is an area we should come back and think about. Because Alan, you're right. The dollars saved don't find their way back to the dialysis unit.
All right.
So, Dr. Garrick, do you have any closing thoughts before we end today's webinar?
Well, we had one quick thing, not quite related to MedRec, but we just wanted to call people's attention to the transition of care survey that ANNA is now doing that mirrors the survey they did on the culture of safety, and we'll give everyone in the stakeholder group the link to that because we'd like to encourage participation. And to let everyone know that the next webinar that's scheduled is going to be on infection control, I think, and that's coming up in November 10th, I believe.
November 10th at 3 p.m. Eastern Time on November 10th, yes. On
November 10th, and we'd like to encourage everyone to continue to spread the word among the stakeholders so we can have a robust participation. And any feedback that you want to share on this one, we are certainly delighted to have.
We'd like to thank today's presenters, and we'd like to thank each of our participants today for taking the time to join us. And we will post the webinar on the patient safety site and notify you of its location in the coming days. And have a wonderful afternoon.
Thanks, everyone.
All right, thank you.